Good morning. I'm just going to go through some notes about grief, normal grief versus complicated or prolonged grief. Some commonly accepted definitions or concepts around normal grief. So, this first one gives us an idea of how we decide what grief is normal and what isn't. So, grief is normal when it stays within the bounds of a particular cultural tradition. So, what we view as normal grief here in more Western societies may be very different from what is considered normal in other areas. So, it's very, very much culturally. The cultural context matters deeply when we're talking about normal grief. An individual with normal grief reaction who has an average level of social support as well as the opportunity to participate in that social support will be able to overcome the grief without extraordinary assistance. So if that person who experiences a loss and is experiencing grief, who has a social connection, who have people who they're able to kind of lean on to, and the ability to access those folks. So we talk about how, as people get older, they may lose their ability to drive, or to hear. Even when we're having hearing loss, accessing your social supports becomes much more difficult. So if a person has social supports, the ability to access those social supports, then using those things should, if they're having a normal grief reaction, mean that they're able to navigate through that loss without much extra help. In normal grief, however painful, the transition is neither overwhelming, interminable, nor prematurely interrupted. So it is normal to have deep pain when we're experiencing grief. That's normal. But that person should be able to continue to live life, to be able to eat, to be able to drink, to be able to sleep. Not to say that those things aren't interrupted or changed in quality, but they should be able to continue to engage with life without um, too much deviance from where they normally are. Okay, so what normal grief is and is not, and this is fairly consistent in our context, um, just for the record. So, normal grief does not mean that the person is going to have a painless experience, and it does not mean that that person is going to get over the loss quickly. We're not saying that a painless or a normal grief reaction is one that doesn't impact the human at all, where they're able to just kind of like flounce through the pain, or that they won't have any sort of interaction whatsoever, or negative impact whatsoever on their life. That's not what we're talking about. Um, Even in normal grief, we might see things like sleep disturbances, and that can include difficulty going to sleep, or waking up early. And so, although folks sometimes may need temporary medical intervention for this, because we know when I'm sure that you guys have had experiences with not being able to sleep, maybe for multiple days in a row, maybe for weeks, maybe you have insomnia. So like when a human doesn't isn't able to get the amount of sleep that they need, that can become overwhelming very quickly. So in some cases, even with normal grief, um, folks may need temporary medical intervention. Although in normal grief, this typically corrects itself. Specifically, the 1 out of 5 folks who have experienced grief um, had a sleep disturbance after the death of a parent within the first 4 months. Then, within 2 years, those same folks who didn't have complicated grief reactions went back to the sleep pattern of their non-bereaved counterparts. So within a relatively short period of time, they were able to kind of like self-adjust. Um, Children who are specifically not yet able to verbalize their emotional experience may have a higher likelihood of sleep disturbances. especially surrounding student children who have had who kind of watched their human die, because they might start to have a fear whether they're able to verbalize it or not, or whether they're conscious of it or not, that if they sleep they won't wake up and dying. So that kind of goes back to what we keep talking about with children, about being as open and honest with them as possible, and having these consistent conversations about what death is, what sleep is, and how they are different. You might experiencing eating inconsistencies or disturbances. And although undereating is more typical in grief reactions, just due to the stress, overeating is also not uncommon, and weight changes may occur. Again, though, what we're looking for is there's a quality and quantity to this. So this might be something that impacts a person for a short period of time, or they may have, slight changes or slight deviances from their normal. But these are things that they're able to kind of adjust to on their own, within their own social network, or having like light medical intervention. Social withdrawal. It is not unusual for people who have sustained loss to withdraw from others, just to kind of, help themselves kind of cope. Though in circumstances of normal grief, this is typically a short-lived phenomenon that again corrects itself. And so treasuring objects that belonged to the deceased, it's common for folks to kind of start wearing the deceased clothes, or, using their mug, whatever that kind of helps them feel attached to and continues that relationship with the person who is dead. We're talking about things like, for instance, this kind of like fits under the continuing bonds theory that we've kind of been talking about throughout. And so what I'm hoping that you're getting from this specific slide is that there are a bunch of different things that could happen in normal grief, that normal grief is not necessarily what things, a way to grieve, but specifically what we're looking at are things that are short-lived, and do not cause their own distress to the individual. Again, it's kind of self-correcting, where the person is kind of able to come out of these coping behaviors on their own, versus complicated grief. So when these are kind of some generally accepted definitions of complicated grief. So when the bereaved person does not move on from the shock and pain of loss towards a substantial return to an active and fulfilling life, they're just unable to reconnect. They're unable to come back to baseline. It's also a grief that an individual may have for prolonged have a prolonged or persistent distress long after experiencing a loss, even when environmental or social support has been strong. So I want you to notice specifically the second part of that definition, when we're talking about even when that person may have social supports that are surrounding them. Maybe they have friends, maybe they have a church group, maybe they have like a club that's around them, and they have people who are able to come and be with that person and support that person and love on that person, but that's not helping move the needle, and reducing the grief even after an extended period of time. And then this third definition, the intensification of grief to the level where the person is either overwhelmed or resorts to maladaptive behavior, or remains interminably in the state of grief without progression of mourning towards completion. So, either we're looking at a person whose grief is so overwhelming that they're unable to live their normal life, unable to eat, unable to sleep, unable to work, unable to connect with their social support, pardon me, or they go into maladaptive behaviors. So we're talking about isolation. We're talking about substance use or abuse. Now, I will say, a person who has a few drinks if they're over 21, or, those kinds of things. That's not what we're talking about. We're talking about, people who are overindulging and consistently. Or a person who is having an extended period of time where they are unable to move out of that space of intense grief. We would expect for a person who has lost a human, or has experienced a loss that is close to them, to have a strong reaction, but it's when that loss, that experience, that grief doesn't begin to abate, that's when we're start to consider, wonder to ourselves, is this something that we need to have some interventions on? Okay, so the DSM-5 does talk about the definition of prolonged grief disorder, and we're going to kind of go into it and look. Um, we're going to look at it. Oh, sugar. I should have foreseen this. I'm going to pause this and um, I'm going to pause this. And all right. Okay. So, what we're talking about when we're talking about prolonged grief disorder um, let me just make sure I'm sharing the right screen. Okay, good. Um, there are a few things that a person must exhibit in order for us to diagnose or to suggest a um, diagnosis, pardon me, of prolonged grief disorder. So one of the first things that has to happen is a time that we're looking at here. So the death has to be at least 12 months ago of a person who was close to the bereaved individual, or for children or adolescents, we're talking about 6 months ago. And then additionally, so these are all things that have to be in occurrence simultaneously. Since the death, the development of persistent grief response characterized by one or both of the following symptoms, which have been present most days to a clinically significant degree. So we're talking about a clinically significant degree. What we're talking about is a symptom which is distressing to the individual, as well as not preventing that person from living a normal life and participating in their baseline. And the symptoms have to have occurred nearly every day for at least the last month. So either or both an intense yearning or longing for the person, or preoccupation with thoughts or memories of the deceased person. And then in children or adolescents, the preoccupation may focus on like the circumstance of death. So we're talking about at least 12 months ago, or at least for a full year for an adult, and then additionally, it most days within the last month of intense yearning or longing and a preoccupation of that human. And then additionally, since the death, at least three of the following symptoms have to be present. So we're talking about identity disruption, talking about, part of you is dead, part of you is gone. You no longer feel like a complete human being. A marked sense of disbelief about the death, so denial, but like to a significant degree. Avoidance of reminders that the person is dead. So this might be one of those situations where you may avoid thinking about the funeral. You might avoid people who want to talk about that person being dead. Um, Intense emotional pain related to the death, anger, depression, things of that nature. But this isn't like a passing sort of situation. This is like a consistent and agonizing thing that is preventing a person from living their life. Difficulty reintegrating into one's relationships or activities after the death, so kind of like a social disconnection. Emotional numbness, it's like a stoicism, feeling that life is meaningless as a result of the death, or a feeling of intense loneliness. So we're looking for at least three of those symptoms from C. D, we're looking at a disturbance that causes clinically significant distress or impairment in the social, occupational, or other important areas of functioning. We're also looking for a duration and severity of a bereavement reaction that has clearly exceeded the expected social, cultural, or religious norms for the individual's culture and context. So again, we want to make sure, and this is fairly new for the DSM actually, where they're trying to take into consideration the cultural context of the person, the religious context of the person. We can't just say, oh, well, the average cis white heterosexual male in Iowa has a grief reaction that looks like this. So anything above and beyond that is prolonged or complicated grief. But we're saying, okay, well, who is this person? What is their social and religious and cultural context? Now are we looking at something that's above and beyond that? And then symptoms that are not better explained by another mental disorder. So if we're looking at a person who already has, say, schizophrenia, who's having trouble coping, we may have more success treating the schizophrenia than we would have trying to add additional diagnoses um, and trying to treat that. So it's kind of like an Occam's razor sort of thing. And then so these are all things, and so we want to make sure that we're looking at all this whole thing in context. So we're going to look at a person, the person whose death they're suffering from was 12 months ago, every day for at least the next. So even until we're a year out from this death, we're not even thinking about this specific diagnosis. So once we're a year out, then we're looking for every day, almost every day for the past month, we're looking at least an intense yearning or longing, or and the preoccupation with thoughts or memories of the deceased person. Okay, and then additionally, we want to have at least three want to. We're looking for at least three of these symptoms to a significant degree. So this again, these are things that are deeply concerning to the individual and preventing them from living their life. In addition to uh, all of these as well. So we're looking for um, I guess somewhat of a blend of these things. And this is going to be, all of these things are going to be to a point where it's interrupting their lives. There's other associated features with this. You can kind of have additional um, symptoms, and that might change the IDC code that you're going to use. And then this kind of says we're looking at a roughly a 10% of folks who experience grief may end up having this sort of diagnosis. And then this kind of looks at the development through the life course and what milestones and traditions. Okay, so I encourage you, if you're familiar with reading through the DSM, I do encourage you to look through that and kind of get an idea. If you're not and you have questions about how to look through the DSM, reach out. We can kind of talk about that. Okay. So, and then I kind of want to talk about what it reasons why we would want to look at a diagnosis of prolonged grief disorder and maybe reasons why it's somewhat considered somewhat controversial to pathologize grief. So, like looking at it from a medicalized lens. So, a pro of having a diagnosis of prolonged grief disorder and the ability to kind of say, to look at a person and say that this is what's going on. So, one, from a um, therapeutic perspective, or be as from a professional standpoint, being able to diagnose a person and give them an IDC code essentially allows you to bill, which, you know, that's not a super like romantic, I guess, reason, but it assists you in being able to provide therapy and bill for therapy so that you can, I don't know, get paid, live your life. That's important if you're a therapist. And then additionally, some folks, and this is not exclusive to a prolonged grief disorder, but some folks find that a label um, and a recognition that they're not alone in their suffering is really very helpful. So if I have a patient come in and they're talking about, they describe all of these things and they say, I just don't know. I can't breathe. I can't think. I can't sleep. All I do is think about this person. It's been over a year and I can't eat and I'm not, I don't even want to go outside anymore. I don't want to talk to my friends. I don't care. And be like, okay, well, based on, we'll go through all these symptoms. You tell me what's going on. I diagnose you, okay, prolonged grief disorder. And then that person says, okay, and this may not be in that moment and it may not be, quickly, but that person may be able to kind of gain a sense of acceptance over what's going on, and normalize this prolonged grief disorder or this complicated grief disorder where we can say, okay, this is what's going on. We can kind of start to give, proscribed steps that we can take to helping, and that might help that person. Um, One of the cons of pathologizing grief, even in a prolonged grief disorder, even when we're talking about someone who's experiencing really very intense grief, is that that might be seen by general society as grief is inherently wrong or diagnosable, and it might kind of take normal human experiences and seek to move them into a medicalized framework where we're seeking to medicate, where we're seeking to charge people for a human experience. So I think there are, because the prolonged grief disorder that kind of went back and forth, when they were talking about adding it to the DSM for many reasons, and it's really very similar to the reasons that they kind of went back and forth for many different diagnoses, and talking about, what is it that we're looking at? What is it that we're actually saying when we diagnose someone with prolonged grief disorder? And what is that actually helping? So I think some people experience a benefit from a diagnosis and some people don't. And that's kind of up to the individual human. But I personally think I'm in the camp of I appreciate knowing what's going on and appreciating a label and saying, like, okay, I have prolonged grief disorder. This is what I'm looking at. These are the criteria, and this is what I can do to kind of take steps and moving along. Okay. So I'm going to have one more little tiny note about that. If you, as a social worker, unless you're an LCSW, you are not like a licensed therapist on your own. You're not going to be, or an LCSWA under supervision of somebody who is an LCSW, a licensed clinical social worker. So, unless you are an LCSWA with supervision or an LCSW, you will not be diagnosing people. And especially for those of you who are not social work students or social workers, I just think it's interesting. I think looking into the DSM and kind of getting an idea of what people are looking for, and how all that works is something that we should all have a little bit of knowledge about. That way, you can have these conversations with your therapist, or your counselor or whomever, moving forward. Okay, I did it. That was pretty short. I appreciate you guys. If you have any questions, please don't hesitate to ask, reach out. I'd be more than happy to kind of speak further with you, um, about anything that we talked about. Thank you.